Welcome to Common Part B Plastic and Reconstructive Surgery Rejections and Denials. I'm Mary Mucko. I'm a member of the WPS Provider Outreach and Education team at WPS. I'll be your presenter today, and I'm joined by my friend and teammate, Leanne Foster. Leanne will be assisting with some behind-the-scenes help. The webinar today is for those people who are wishing to learn about the most common rejections and denials on Part B claim submissions to WPS. CMS does require the MACs, Medicare Administrative Contractors, to include this education in order to prevent future claim rejections and denials. And just as advertised, the information that I'm presenting in this webinar today is actually based on actual claims data. The presentation is available for download from our live events webpage. The page address is in the chat. You can take time now to download it if you haven't already done so. We will be recording this session, and barring technical issues, we will post the recording on our Encore Presentations webpage, where it will remain for about 60 to 90 days. The recording will also post on our YouTube channel, where it will remain as long as the information remains current or until we otherwise decide to move it or remove it. If you have any questions, please place them in the chat. I will answer questions as time permits. If I don't get to your question, I will email the response to you after today's webinar. If you have a question on a specific claim that is in processing, one that's already denied or otherwise sent to Medicare, I will be unable to answer questions relating to that specific claim. You must contact customer service so they can access the claim edit trail and claim history in our system. We include this disclaimer in all our live events, and this presentation is for educational purposes only. I did make every effort to verify the information that I'm going to provide is current and accurate. However, it is subject to change. It is on the CMS website that you will find the Medicare rules that determine final coverage. These laws and regulations and rulings will always prevail. CMS prohibits recording this webinar for profit-making purposes. We ask that you do not record or use screenshots during today's presentation. We will create an encore of the presentation, and you may use that for future reference. Here is the agenda for today's webinar. This is exactly what the advertisement stated. Today, our goal is to share with you the most common rejections and denials for plastic and reconstructive surgery claim submissions to WPS. I'll define rejections and deniils, reveal the reasons for those rejections and denials based on the data that I pulled and analyzed, and I'll discuss ways to fix and avoid these. And I'll provide you with many resources. This is a lot of information to share in 60 minutes. I'll be moving rather quickly through the slide deck, and I may ask you to review some of the information, mostly those resources following this live presentation. That information is mostly those helpful resources that I've gathered and included in some slides at the end of the slide presentation. Now, if you have any questions, I'll tell you later how you can send them. Now, based on the American Medical Association's copyright notice for CPT codes, descriptions, and other data, I've included this CPT copyright notice in my presentation materials. Your continued participation in this presentation infers that you agree to the terms of this copyright notice. In order for me to discuss rejections and denials, I do need to provide a bit of information about the claim process. Now, based on a law that requires that most providers submit claims electronically, reports generate to confirm claim receipt, and they report more specific information about the data requirements. Now, one of these reports is known as the 276-277 report. The Medicare 276-277 companion guide was prepared by our Electronic Data Interchange or EDI staff, and that companion guide will actually help submitters understand claim requirements and know when they need to correct or resubmit the claim in order for that claim to pass our system pre-pass edits. Now, claims that move past those pre-pass edits are going to generate a remittance advice, also referred to sometimes as the RA, sometimes we simply call it the remit, and others call it the notice. There are two formats for the RA, the Electronic Remittance Advice or the ERA, and the Standard Paper Remittance or the SPR. Now, with few exceptions, most providers receive the Electronic Remittance Advice. That RA provides important information to the provider. For adjudicated claims, you can find information about adjustments, denials, missing items, refunds, and sometimes even offsets. When looking at a remit, you will find various reason and remark codes. These are typically in an alphanumeric format, and when claims pay differently than billed, a claim adjustment reason code appears on the remittance advice. Now, sometimes a remittance advice remark code will also appear, and these expand on the details that are described by a reason code in order to provide more details about the adjustment. Now, another type of code on the remittance advice is a group code. Group codes assign financial liability for any unpaid balance on the claim. There's a couple of different group codes. A CO is standing for contractual obligation, and this means that the provider is liable and can't bill their patient. A PR group code on the remittance advice means that the patient is financially responsible. WPS hears a lot of comments about these codes. Providers often state that these codes are too cryptic or that they contain outdated acronyms. While we'd certainly like to help, another contractor, not WPS, maintains these codes for CMS. You can find a link to the code lists on the Washington Publishing Company's website. It is on the WPC's website where you can find contact information. Should you wish to suggest a change to the code lists, including code explanations. I'm going to take a break for just a few seconds. Thanks for standing by. This slide shows a side-by-side comparison of rejections versus denials. I do want to mention to you that there is a typo on the slide deck that you have and may have downloaded. There is a CO15 that appears in one of the bullets. That should be CO16, just as I've indicated here on the slide that you're looking at in the webinar presentation. A rejected claim is rejected. It's unprocessable. That's what CMS calls them, unprocessable. Rejection is really very, very different from a denial, and I think a lot of people, even myself, I find myself sometimes using these interchangeably, but they really are different. It's important to understand the difference. A rejection is returned on the front end. The claim is never adjudicated. The reason why it's rejected is because something is illogical, something's missing, or in an incorrect format. Maybe the information on the claim is incorrect. Those rejected claims have no appeal rights. What you need to do is resubmit the service. Now, on a rejected rejected claim remittance advice, you will see an MA 130 and a CO16 code on that RA. An MA 130 is a Remark code that states that the service is rejected. It states that there are no appeal rights, and the CO16 group code states that you can't bill the patient for that service. The patient is not liable. Now, a denied claim, on the other hand, is adjudicated. When something denies, it does so because it fails to meet payment criteria. Now, this could be due to a law, which is a statutory requirement. It could be because the services are not medically necessary. Frequency edits or utilization parameters, those claims or claim lines that deny due to frequency, are considered a form of medical necessity denial. Other reasons for denials could be due to eligibility. Both the provider and the beneficiary have to meet eligibility for Medicare. Sometimes the claims deny because eligibility is not met. Now, on a denied claim or claim line, most often there will be an MA01 Remark code, and that provides appeal rights. Now, I say most often, there are a few exceptions where there are not appeal rights, and I'll talk about one of those a little bit later on. For denied services, of course, the patient liability is determined. Now, it's important to understand the difference between rejections and denials, because you'll need to know whether you need to correct or appeal the claim. After reviewing your remit, you need to choose your action. For an unprocessable claim or one that is rejected, you're going to need to fix the error and resubmit the claim to Medicare. If the claim or claim line denied, there may be multiple actions to choose from. You may be able to simply resubmit the service for a denied service. You might use the clerical error reopening process to correct errors, and CMS defines clerical errors, including minor omissions or errors, as human or mechanical errors on the part of the party or the contractor. Another action to consider is an appeal. The remittance advice will provide those appeal rights with few exceptions, and I'll discuss this again a little bit later in the webinar. Registered users of the Secure Net Access Portal, what we call SNAP, may request a clerical error reopening, or actually render a clerical error reopening, or request an appeal by using that self-service tool. And just as a reminder, those self-service tools often offer the most efficiencies. Our portal user manual provides illustrations and step-by-step instructions on how to use the portal features. For claim denials, most often you can request an appeal. The purpose of the appeals process is to ensure the correct adjudication of claims. Physicians, suppliers, and beneficiaries all have the right to appeal claim determinations that are made by the MACs. The beneficiary or their representative can request an appeal on any service processed for them. Providers and suppliers, on the other hand, may appeal services for which they accepted assignment. But for unassigned claims, providers and suppliers can act as the beneficiary's representative if the beneficiary signs an authorization statement. Just as an example, the CMS 1696 appointment of representative form would allow the provider to act as the beneficiary's representative if the beneficiary signs that. In addition, providers and suppliers can request a redetermination, that's the first level appeal, on an unassigned claim if Medicare denied the service is not reasonable and necessary, or if the provider billed in excess of the limiting charge. And in that case, the provider would need to refund any fees collected from the beneficiary. Now, the first level of appeal is the redetermination, and this is the only level of appeal that is rendered by the Medicare administrative contractor like WPS. Time frames apply to each of 5 levels of appeal when you're submitting the appeal. Additionally, there is a minimum amount in controversy that applies to level 3 and level 5 appeals. You can combine like denials on more than one claim in order to reach that amount in controversy. Check out how to appeal a claim determination on our website. It includes a lot of great information when you need to appeal a claim determination. Again, always consider using those self-service options in SNAP, our Secure Net Access portal, for more timely processing. Now, one of my favorite appeals resources is the one that I've included and shown on this particular slide. Your handout actually links to the CMS fee-for-service appeals process flowchart. This flowchart is updated by CMS annually. This is the newest form or newest flowchart for 2025. If you look at the small print way at the bottom of the flowchart, you will see that it does state that this chart reflects the amounts for calendar year 2025. So this just changed from the 2024 version over to the 2025 version. And the reason why I like this so well, and I like to share it with learners, is that this shows all 5 levels of the appeals process. The first level is done at the MAC. It is the redetermination. The second level is the qualified independent contractor reconsideration. And so on and so forth. You can see this shows the 3rd level of appeal, the 4th level of appeal, the 5th level of appeal, which is federal district court. Now, for each of these levels of appeal, the 5 levels of appeal, there is that time frame you need to follow or keep in mind when you're submitting a request for the appeal. You have 120 days to file, this flowchart says, in order to file a redetermination. What I like about this is it also tells you within these boxes how long the contractor has to send you their decision. So while you have 120 days to file the first level of appeal, there's a 60-day time limit that the MAC has for sending you notification of their decision. And this repeats, of course, for all 5 levels of the appeal. This also includes those amounts in controversy that I talked about for levels 3 and level 5. And you can see here the 3rd level of appeal is the Office of Medicare Hearings and Appeals. Sometimes people call this the ALJ hearing. ALG stands for Administrative Law Judge. Within this box, you can see that the AIC is equal to or greater than $190. That's that amount in controversy. And remember, I said you can combine claims in like denials, in order to request an appeal if a single claim doesn't have an amount of controversy equal to or greater than 190. And of course, that federal district court, that 5th level appeal, has the amount in controversy also, and that's included here within this box. So a great tool that I like and like to pass on to learners. All right, now the next portion of this webinar, just as advertised, really focuses on the data. Now I used a tool that we call the data dashboard in order to pull the data that I plan to share with you. This data dashboard is an interactive tool designed by one of our data analysts in our Insight department. And Insight is simply the name of the unit at WPS that's responsible for mining data and data trends, among other tasks and responsibilities. So this dashboard allows people like Leanne and me to go out and pull information on rejections or denials based on our specific needs. Now, there are different ways for outreach to view the data. We can, in an instant, just by the simple pushing of a button, view rejections or denials in many different ways. We can drill down by state and even county. We can look at the dashboard to see the reasons for rejections and denials. We can look at the most commonly denied codes. We can even drill down to specialty. And that's what I did for this presentation today. for plastic and reconstructive surgery rejections and denials. We can also use this dashboard to view trending, and trending alerts us to those spikes or increases that require education in order for providers to know how to submit claims correctly. So the data that I am sharing today is all Specialty 24 submitted claims for Jurisdiction 5 and Jurisdiction 8. I do need to make a correction to this claim. However, the data that I wanted to provide today is newer than the dates shown on your slide deck. So the data that I actually analyzed is shown here on this slide. Specialty 24 claims, submission dates September 1 of 2024 through November 30 of 2024, with the data last refreshed on 12/16 of 24. So this means if you submitted claims for this date range after December 16 of 2024, that data will not be included in the data that I analyzed, or it was not included. So for those of you that are wondering what a specialty code is, I've mentioned Specialty 24 a couple of times. It's a 2-digit code assigned to WPS providers when they enroll. Now, during enrollment, providers self-designate a specialty. So while a provider can designate a single or a primary specialty, they can also designate a secondary specialty and other specialties, but it is only that primary specialty, the one designated, self-designated, that is used during initial claim processing. So there are some situations where a provider will request an appeal and they'll stipulate that their secondary specialty for Medicare is such and such in order for Medicare to make payment, because Medicare, the computer claim logic or the logic used during initial claim processing, is only based on that primary specialty. And today we're talking about Specialty 24, plastic and reconstructive surgery. So let's reveal the data. So based on the data that I analyze, here are the most common reasons Medicare rejected Specialty 24 claims. And you'll see numbers following these reasons. That's the number of claims that were rejected within that time period that I looked at. The most common reason for rejections of your claims, of your specialty claims, is invalid or missing modifier, followed by missing, incomplete, or invalid billing provider primary identifier. Another reason for rejections for Specialty 24 is that the authorization number is missing, invalid, or incorrect. Missing, incomplete, invalid name, strength, or dosage of drug stands for 32 or represents 32 rejections. And finally, for the claims I analyzed, or the claim data I analyzed, the fifth most common reason for rejections is that the claim must be submitted to Railroad Retirement Board. In other words, the claim must be submitted to Palmetto GBA, not to WPS, because Palmetto GBA is the Medicare administrative contractor that's responsible for processing claims for railroad retirees. So in the description for this webinar, I said that I would review the top reasons. I want to take it a step further and share with you the services, the top rejected codes for your specialty. The most commonly rejected code for your specialty based on that data I analyzed is the 99213, which is an evaluation and management service. And the reasons are listed here on this slide: missing, incomplete, invalid billing provider primary identifier. In other words, the provider identifier on the claim was missing, it was incomplete, it was invalid. So the claim rejected. What you need to do is fix it, resubmit it. The second most common reason for rejection, I caught myself there, of 99213 is invalid or missing modifier. And third, facility or laboratory name and address or PIN is missing. Now, CMS, in their internet-only manual, publication 100-04, that's the Medicare Claims Processing Manual, provides both the claim form instructions, for a paper claim, and also the electronic claim requirements in various chapters of that publication. 99203 is a new patient evaluation and management service. Let's look at the reasons that denied: missing, incomplete, invalid billing provider primary identifier. One evaluation and management code for service level is covered per course of care. What this translates to is you can only bill one new patient service. After that new patient service, the patient is then considered an established patient, not new patient. And finally, the claim must be submitted to the Railroad Retirement Board. I talked about that earlier. Palmetto GBA is the contractor to submit claims to for those patients or beneficiaries who have Railroad Retirement Board benefits. And when you're looking at a Medicare card, your patient's Medicare card, if they are a Railroad Retirement Board beneficiary, it will state that across the bottom of the claim. The emblem also on their cards is different than that of original or traditional Medicare. That is not Railroad Retirement Board. More E&M codes, 99212 and 99204. Same reasons here: invalid, missing modifier, missing the provider primary identifier. For 99212, one of the top reasons that code is rejecting is that the procedure code is inconsistent with the modifier that was reported on that claim, or a modifier is missing. Remember, for rejected claims, you need to fix them and resubmit them. 99204, once again, primary identifier issues. Claim must be submitted to the Railroad Retirement Board. And this one of the top reasons for rejections, is an invalid or incorrect ICD-10 code. Maybe that ICD-10 code is no longer valid. Maybe it was keyed incorrectly. These are the kind of things you would need to check if your claim rejects for that reason, or claim line. And the 97605 is rejecting for invalid or missing modifier. Pretty straightforward on the remittance notice, the reasons why services are being rejected. I want to show you, in addition to these top rejections, some trending, what we can look at. I mentioned this earlier. We look to see if there's a spike in reasons for rejections or denials, so we know what we need to do a better job on as far as education. We need to make certain that we're bringing this to the provider's attention. And this is just one I chose because there's a 500% change in these within that time period that I analyzed data for. Field 11 of the CMS 1500 form must be completed. There was 12 rejections the current 3 months. There was only 2 rejections the prior 3 months. This is a 10 claim increase and a 500% change. Field 11, for those of you that aren't familiar, is that field on a claim form where providers need to report if there is other insurance that is primary to Medicare. If there is not other insurance primary to Medicare, you can't leave field 11 blank. It's a required element or field on the claim form. You need to write none if there is none. Don't leave it blank. All right, we talked about the top reasons for rejections. Let's talk about denials now. Common denial reasons for specialty 24 claims. Separate payment not made for this service, 588 claims denied. This is a bundling situation, and I'm going to talk about some of those actions you can take to prevent these a little bit later on in the presentation. But separate payment not made for this service is a flag, meaning that this is a bundled service. Now, I will say that when we are looking at data like this, we do need to consider that sometimes CMS requires that you report a particular item or service that we know is going to deny because it's a reporting requirement. We do take that into consideration when determining whether or not we need to educate on a particular common denial reason. Look at the next one: duplicate charge paid the month or MMDDYY means a particular date. So the duplicate charge paid on a date on claim ICN, and you'll notice those X's. If this actually printed out on a remit, it would have a date there. It would have the claim internal control number. So duplicate charge paid, 467 claims denied or claim lines denied in that 3-month period because it was a duplicate. This has been problematic, duplicate denials, for as long as I can remember. We often provide education that tells ways you can avoid these duplicate denials. Sometimes you need to add a modifier to avoid a duplicate denial. Some providers just automatically submit every 30 days. If you have a billing service that does this, tell them to stop. It is considered abusive. That's 467 claims that were denied, so I mean, if you put a dollar amount in each of those claims, it's money that is being spent needlessly, so it is considered an abuse. It is an abuse once educated, if once a provider is educated about a particular abuse, could become or could be considered fraudulent if it continues. So we want to discontinue submitting charges just on a cycle basis, make certain you're taking a look at the remittance advice to determine whether your service was submitted and denied, so you can avoid those duplicate charges. Let's take a look at the next one. This is kind of one of those that I kind of alluded to earlier when I mentioned that sometimes providers contact us and say, this is a little cryptic to me. Collection of fee-for-service during periods of managed care, 281 denials. Well, what that translates to is that this particular beneficiary has elected Medicare Part C. They're eligible for Part C or Medicare Advantage, not traditional or original Medicare. So in this case, the claim is denied. It should be processed by the Medicare Part C plan. Next, units of service are exceeded. What this are those medically unlikely edits that are part of the National Correct Coding Initiative out on CMS website. And again, I'm going to talk about using some of the tools that we have available in order to avoid these rejections and denials a bit later in the presentation. Pre and post-op care included in surgery, 203 denials. This is global surgery billing. For many surgical procedures, Medicare makes reimbursement that includes the pre-op and the post-op care. So if pre or post-op care is billed in addition to the surgery, the claims processing system recognizes this, and that pre and post-op care will be denied. 203 denials. So what are the top denied codes for your specialty? 99024, separate payment may not be made for this service. That's that post-op visit code. 99203 is an evaluation and management service. New patient. The reasons this is denying is collection of fee-for-service during periods of managed care. Can pay only one initial, excuse me, can pay only one initial visit per specialty. If there is a group billing for evaluation and management services for a patient, Medicare will only pay one initial visit per specialty. Claim must be sent to the employer group health plan first. This is a Medicare secondary payer denial. This particular beneficiary, based on information that's provided and available in CMS's Common Working File, that master computer system that's for each beneficiary where all that eligibility information is housed, that particular system or within that claim system is the knowledge that an employer group health plan is required or responsible for paying the claim first. So if it comes to Medicare first, that's that service is going to deny with this type of denial reason. Next up, 99212 and 213. Again, we're seeing the pre and post-op care included in surgery. You cannot separately bill the patient for an E&M service that is included or payment when payment is included for that service with the surgery. Again, we have periods of managed care or collection of fee-for-service. For those services, you're going to need to submit that claim to the Medicare Part C plan. And again, the claim must be sent to the EGHP first. So very, very similar, these top rejection or top denials. 14302 is a surgical procedure, and for this particular service, the top reason this is being denied is when those units of service are exceeded. That is those medically unlikely edits. I've got slides included in my presentation that tells you where you can find education to avoid this particular kind of denial, similar to all of these, but we have provided some webinars in the past that actually demonstrate how to use the National Correct Coding Initiative edits, including the medically unlikely edits. This code is also being denied because Medicare does not pay for this many services in this time period. This says to me that there's a frequency parameter for this service, and that means frequency edits apply or kind of translate to medical necessity. Anytime something denies for medical necessity reasons, that should be a flag to you to know that you should consider presenting your patient with that advance notice of non-coverage or that advance beneficiary notice of non-coverage, that ABN form, before that service is rendered. Because if the service is denied by Medicare, and if that form is signed by your patient in advance and you followed all the instructions for doing so, that alleviates the liability for those services. Then you would be able to bill the beneficiary for that, those charges for that denied service. Without the ABN, you would not be able to do so. Duplicate charge paid on claim ICN, duplicate of a charge already submitted. Sometimes claims denied because it's a duplicate of another service that's currently being processed. So many reasons for duplicate denials here. Again, what's happening, I believe, because of this code being denied often for your specialty, is that when it's denied, you can't just simply submit another claim and hope that it'll be paid, because it's going to deny as a duplicate. What you're going to need to do is request that appeal. Send in that documentation or the information you have that validates why you believe the service should be covered. Don't just submit a new claim. It's going to deny as a duplicate. Procedure must be billed with the primary service. That means that this is an add-on code and you must bill the primary service before billing it. So perhaps the primary service was not yet submitted. This too is a National Correct Coding Initiative type edit. Here's the trending that I'm sharing with you for denials. And remember, there's many reasons that show up in these trending reports, but I do want to point this one out to you because this one not only affects your specialty, but specialties across the board. So we're trying to provide education about timely filing. The time limit for filing your claim has expired, and this is one of those exceptions, folks, that I talked about earlier, where there are no appeal rights. If your claim denies for timely filing, you have 1 year from the date of service to submit your claim to Medicare. If it denies for timely filing, you have no appeal rights. 78 of these, the current 3 months, 48 denials the prior 3 months, 30 claims increase, representing a 63% increase in this denial over a 3-month time period. One of the things I mentioned to you is that during this 60 minutes, we have a lot of information to go over. I'm not going over every single thing that I've listed as a resource for you, but I do want to show you a resource that will help with this particular denial, not rejection. This is I pulled over our website, the WPS website, and I do have the link to the website listed in your handout. But if you go to our website, and I like to search, I'm not a navigator, I use search a lot. So I'm searching for timely filing up here, and you'll notice that some resources pop up here. Timely filing of claims. I'm going to choose Part B. It really doesn't matter if I choose J5 or J8, it's the same. We have a resource on our website that speaks to timely filing of claims. And one of the things that keeps coming back, and the reason I'm showing you this, is that providers often ask us to reopen a claim that's been denied for timely filing when another insurance comes back years later and they recoup their previous payment. So that is why there is the delay in submitting the claim to Medicare. This tells you in this resource that CMS does not accept errors caused by incorrect third-party payment as a justification for not submitting a timely claim to Medicare. There's actually some information here in this particular resource on our website from the IOM 100-04, that's the Medicare Claims Processing Manual, that speaks to this. Here is that verbiage that CMS says that third-party error in making that primary payment determination does not constitute good cause for purposes of reopening the initial determination or a redetermination. If you scroll down this particular resource, there are some reasons where we may extend that late filing limit. This resource tells you how and what you need to send us in order to file that waiver to extend the timely filing unit. Tells you where to send it and so on and so forth. I'm on the J8 MAC Part B website. You can see up here in this ribbon. If you want the addresses for J5, you could simply come over here and click on J5 MAC Part B, and then it would switch over to our J5 states, okay, versus J8 states. So make certain you are on the right website. There's a portion of our website. Okay, so that is information then about timely filing. So for each of these, I've got fixes on the next few slides that pertain to rejections. I have corrections on these slides or how to avoid denials. So this particular slide speaks to those modifier issue fixes. When I say fix, that means you fix it, resubmit it. So this relates to rejections, not denials. Verify that the required modifier is there, that the modifier works with that procedure code. Make certain that the modifier is valid for the date of service. On our website, we have topic centers. If you click at the top of the page, you'll see the various topic center. It is under the Claims Topic Center, Guides and Resources. If you scroll down, you will find modifiers. I'm going to go ahead and click on modifier, and you can see the subcategory is modifiers. This, folks, takes you to the many modifier fact sheets we have available on our website. Provides you with a definition, tells you what's the appropriate use, what's not appropriate, sometimes some general information, and so on and so forth. Some of these modifier fact sheets actually have the CPT code or HCPCS codes that are valid for that particular modifier. So very helpful. Something to help you avoid those rejections. Authorization number issues. This was one of the reasons for top rejections for your specialty. This has to do with that prior authorization number that's needed and required on the claim form. If you don't follow the rules for obtaining that prior authorization and reporting it accurately on your claim, your information or your claim is going to reject. So you need to make certain that the procedure codes that require this authorization are being acted upon, you're keying it correctly, the format is correct, and you're reporting it in the proper place. How do you know how to do all of this? We have we have a playlist out on our YouTube channel for the very many webinars we have held about the prior authorization process. We also have articles on our website, and those are included, listed in the, or links to them are listed in slides in your slide deck, where I have given you many resources to avoid rejections and fix denials. Or not fix them, but how you can appeal them or how you avoid them altogether. Medicare secondary payer fixes, those number issues. Make sure you're asking your patient, is there other insurance that's primary to Medicare? Use the tools that CMS makes available in order to verify your patient eligibility. Make certain you're completing item 11 on the claim form that tells us, no, there is no other insurance to Medicare. There is none. Remember, you need to fill out that form. Or fill out that field on the claim form. Here is the claims processing manual that provides the data set for the 1500 claim form. It is in this manual also that CMS provides the directions for the electronic claim. One of the tools I like to show to providers to make certain that they're filling out the Part B claim forms correctly, those electronic claim forms. If you go to our website, and I do have the link to this crosswalk in your handout, under quick links is EDI. This takes you to our EDI website. If you scroll down, choose Medicare EDI, you will find here the crosswalk from a paper claim form to an electronic claim form. This is the page also where you'll find those companion guides that I talked about at the very beginning of this presentation, the 276, 277 companion guide. Here's the crosswalk. This shows you a crosswalk from a paper claim to an electronic claim. In other words, if information, this tells you the information, the requirements for the 1500 claim form. So in other words, if in item 19, this tells you what you need to report over here. If it goes in item 19 on a paper claim form, where does it go on that electronic version? This is the crosswalk and tells you where do you need to put that, what the format is, where the loop is. And there's also this status column on this crosswalk. It says S, some of them are R. If I go down a little bit further, I'll find some R's. Here's an R. R means this: the data is required on the claim. And S means that data element must be completed if other conditions exist. In other words, it's situational. Okay, so this is a great tool for helping you recognize what you need to report on a claim and in what format. Moving on here, MSP resources. Some of the claims that we talked about today are rejecting or denying for MSP reasons. There's a fact sheet available on the MSP questionnaire, Medicare secondary payer webpage on CMS's website. And then, excuse me, I have links here to our YouTube channel, which includes an MSP playlist, recordings of those previously held webinars that speak to Medicare secondary payers. So lots of great resources. These are exactly what's going to help you fix those rejections and avoid those denials. Patient eligibility fixes. Make sure the patient name and MBI exactly match. If there is a middle initial on the patient's Medicare card, make sure that middle initial is appearing on your claims. Make certain you are submitting your claim to the correct payer. We've talked about the Railroad Retirement Board Medicare Administrative Contractor. We talked about Medicare Advantage plans also. Another one that pops up from time to time is the United Mine Workers of America that process claims for those coal workers and such, or coal miners. Those are patient eligibility fixes. There's also provider number fixes. This was one of the top reasons claims are rejecting or denying for your specialty. Keying errors happen. Make certain the information is being entered that needs to be entered. Make sure there's no keying errors. Check your provider enrollment records to make certain the information there is valid. Make certain that your primary specialty is being reported correctly. If that changes in time, you can contact our provider enrollment and change that primary specialty to another specialty. Make certain that rendering providers are associated with billing providers. In other words, if a clinic is billing for a service, make certain that your rendering provider is associated with the clinic number. Rendering providers associated with billing providers. This happens too often for those non-physician practitioner claims that we're having. They need to be associated with the billing provider. Ordering provider information entered is another one. Many of the services, most services require an ordering physician or provider. Make certain you're entering that on the claim form in the appropriate place in order to avoid those rejections. Now we're switching to denials. I just talked about fixes for rejections, those that are most common, of course. Um, Make certain that you're not automatically resubmitting prior to establishing the status of that particular item, the payment for that item. This is what I talked about earlier. Don't just submit claims on a 30-day cycle basis. Don't use a billing service, or don't let your billing service submit every 30 days. Keep in mind the payment floor, the amount of time Medicare needs to hold that claim in order to before it can make payment. Make sure you're billing appropriately using appropriate modifiers. Sometimes this is what's going to avoid those duplicate denials. Avoid MSP denials. Make certain you're verifying your patient whether the patient has insurance that's primary to Medicare. Make certain you're submitting all of the items on the claim when an MSP situation occurs. There's various fields on a claim that have to be filled in so that you can report information about that primary insurer on the Part B Medicare claim. Make certain you're completing all of the required elements for that. Avoiding bundling denials. We talked about a few different types of bundling denials. Check the status of the procedure code for the date of service. Make certain that your service wasn't designated as a bundled service, one of those services on the relative value file. CMS's relative value file has that status code column. If there is a B in that column, that means that service is bundled and you will never receive separate payment for that. Make certain that you are applying the National Correct Coding Initiative edits correctly. Other types of bundling can involve in those situations where the patient's enrolled in a hospice or where there is skilled nursing facility or SNF consolidated billing issues that apply. These could result in those bundling denials. We have recorded multiple webinars in the past that show you how to use the National Correct Coding Initiative edits. Those that are those procedure to procedure edits, which would result in the bundling type denial. Evaluation and management denials. There was a few of these today that made your top lists. Those, you can only bill one new patient service within a 3-year period, same specialties, same clinic. So make certain you're verifying the status of your patient. Can you bill new patient versus established? Keep in mind those global surgery period. Pre and post-op care is going to be included in the reimbursement for surgery, so you can't separately bill for those, or Medicare won't make separate payment. Concurrent care, this is when more than one person of the same specialty is seeing the same patient the same day. If you're in an organized clinic, you need to combine those services and code to the greatest level that you can, but you can only bill the service once if you're providing concurrent care. Timely filing. I talked about this earlier and I actually showed you that article, and here is the link way at the bottom of the slide, the link to that timely filing resource that's available on our website. Avoid timely filing denials. Make certain that you're submitting that claim to Medicare, even if you think that someone else is responsible for it. That shows that you submitted that claim timely, even if Medicare doesn't pay it. So that is one thing you can do to avoid these timely filing denials or the availability of those rights to that waiver. So make certain that you're getting that claim in, even if you think someone else is primary. Here is more information about the correct coding initiative edit denials. There is a policy manual that goes along with these NCCI edits. Very, very great information in there. I've included the specific links to the procedure to procedure code edits, which is the bundling edits. Here is the link to the medically unlikely edits. This is when the number of units reported exceed the amount that Medicare will allow on any given day. Those types of denials are appealable, so you can submit your appeal. We also had hitting on your list, one of your top reasons is that particular procedure code. It was 14302, I believe. That's an add-on code, and you need to make certain you're billing that primary code also so that we can make payment or consider payment for the add-on code. Here is a great resource. This actually tells you how to look up all of these edits and how to apply the payment logic to them so you know how to submit them correctly to Medicare. More resources and tools. Here is the requirements for Medicare claims, and this is that link to the crosswalk I showed you earlier. Let me grab this one, the one that looks like this. This is what I'm talking about, the crosswalk. Okay, so if the claim form shows what you need in item 1, for example, where does it go on the electronic claim? And what is it that you need to report there? What are the requirements? So that's what I'm talking about when I'm talking about the crosswalk. So claim form instructions and crosswalk. We have on our website a resource that's titled How to Correct a Rejected Claim. And this is I talked earlier about reason codes, remark codes, and group codes. This particular article is arranged by the reason and remark codes. So I'm going to pull it up really quick here and get it over to you. How to correct a rejected claim. So you can see what I'm talking about here. Here's the resource. And here are those remark codes that I talked about. So if on your remit something is rejecting with this remark code, here's how to fix it. Okay, so arranged by remark codes. Similarly, we have a resource on our website, Common Claim Denials, which tells you actions to take to avoid common reasons for denials. Bundling, duplicate edits, entitlement denials, provider number denials. So this too is arranged by reason and remark codes and also by category. You know, why is that particular item or service denying? Here are WPS resources. We have our website on the front page of our website. I'm going to pull that over for you. Front page, I should say home page, not front page. We have this code lookup tool. This is where you can enter a procedure code. I'm just going to choose one and click search. I chose to look up LCD and articles, and there are no matches. This is a great way for you to check if there is frequency parameters that are published or policy guidelines that apply for a particular procedure code. Keep in mind that the article is what includes the procedure codes. Unless this is included in the title of an LCD, it's not going to hit as a match, but it'll hit. That's why we have LCD and article together, because articles, not LCDs, include the actual CPT or HCPCS codes and ICD-10 codes. Live events are those upcoming webinars. Encore presentations are recordings of our education. And of course, we have our YouTube channel. Got ahead of myself here with my scrolling. I talked about Medicare Advantage earlier today. When do you need to submit that claim to the plan? So we have some informative videos about MA plans, We have a playlist. Last I counted, I think there was 47 videos for evaluation and management services. That'll help you code those or help you know how to code those new patients versus established patient, only one per specialty, those types of guidelines. Eligibility issues, we talked about those today. Here is a fact sheet that CMS has written. There's also the review contractor directory, the E&M services guide. We have a global surgery resource. This is information about the IVR where you can find claim status and details. Our CMS, our WPS SNAP Secure Net Access Portal will help you check eligibility, claim status, claim details. If something denied, you'll find a more info button listed under claim details. And if the particular line item denied, let's say because of a policy, what you're going to find in that portal is a link to that particular policy. So some great information. Our portal user manual instructions include how to do that. I will answer follow-up questions and tell you how you could submit them in just a moment. In a few minutes, you will receive an automated email from WebEx. It's going to thank you for attending. Do not delete it without reading it if you are seeking continuing education units. This email that you will receive contains a certificate of achievement. It will look like what you see here. The red box on the bottom specifically will include your name, the name of this event, the date, and the contact hours. This is what you need to send to an accrediting organization or body in order for you to request that they award you with continuing education units. WPS does not do that. You will need to take this and submit it to them. If you join by phone, you will not receive that automated email from WebEx to thank you for attending. But if you need a certificate of achievement, you can send an email to our education mailbox. It's at the very bottom of this slide and on the next slide. Include today's date, the name of the webinar, and the telephone number you called in. After we verify your participation, we will send you that certificate of achievement. Here, folks, is the instructions for sending any questions you think of in the next 7 days to me. If you've submitted one in the chat that I haven't answered, I will make certain that it was answered either in my prepared remarks or I send you an email with the answer to it. Claim-specific questions, remember, must go to customer service. If sending us an email with a question, make certain that you send it to the email shown on this slide. In the subject line, put today's topic. Specialty 24, rejections and denials. You can certainly abbreviate, but remember, claim-specific questions have to be handled in customer service because people in provider and outreach like Leanne and I do not have access to that claims history or the edit information. Please take a few minutes now to complete a survey. Tell us what you liked, what we could do better. Suggest topics for future education. Your feedback really is invaluable. It ensures that our education is timely and effective. There's different options depending on your preference. This survey is so important that we're going to give you one last chance when you close out of the webinar today to complete it if you've not already done so. When you exit this webinar, you will be directed or redirected to the CMS Qualtrics page for the survey. The destination site is the one that's highlighted here on this graphic that shows the yellow triangle at the top. If you've not already completed the survey, this will provide you with the opportunity to do so. Please, we need your feedback. CMS wants to review these surveys and see the feedback you're providing on your customer experience with WPS. On behalf of myself and Leanne and all of Provider Outreach and Education, I do want to thank you for your participation. I know everybody is so very busy these days. We look forward to your survey comments and hope to have you join us at future events. You may now disconnect. Thanks, everyone.